Welcome to this edition of Conference Highlights, an accredited continuing education activity. This brief expert video will highlight important clinical findings presented at the conference.
Hello, and welcome to this clinical highlight titled Hematologic Cancer Updates, Spotlighting Key Advances in Leukemia, Myelodysplastic Syndromes, and Myelofibrosis. I'm Dr. Raajit Rampal, Director of the Myeloproliferative Neoplasms Program at Memorial Sloan Kettering Cancer Center. In this clip, I will highlight the key data that were presented at ASH from December 6th to December 9th in Orlando, Florida. So to begin with, we'll start by talking about leukemia. There are some key updates with regards to trial data, but also to guideline data. And I'm going to start with the ASH clinical practice guidelines on AML in older patients. It's important to keep in mind that these are practice guidelines and these are recommendations that are scored with regard to the depth of evidence. And so, of course, these are not hard and fast rules, nor should they be interpreted that way, but rather these are guidelines that the committee has put together based on the available evidence. And so I'll go through some of the key questions that were put forth and the recommendations of the committee. I would certainly encourage anybody to refer to the actual guidelines themselves and to look at the data themselves that was presented. But on a high level, let's start with some of these questions, one of which was, should older adults with newly diagnosed AML who are candidates for anti-leukemic therapy be offered anti-leukemia therapy instead of best supportive care only? And the recommendation here was to proceed with anti-leukemic therapy over best supportive care. I think increasingly with the newer therapies that we have, it becomes easier in some respects to treat our older patients. Number two, should older adults with newly diagnosed AML who are candidates for anti-leukemic therapy receive conventional induction plus post-remission therapy, HMA or LDAC monotherapy, or HMA or LDAC plus ven? And the recommendation here, which again, everything is graded, in degree of evidence, was conventional induction plus post-remission therapy, or an HMA or LDAX-based induction plus post-remission therapy in combination with venetoclax, importantly. Going forward, should older adults with newly diagnosed AML who achieve remission after one or more cycles of conventional induction therapy receive post-remission therapy versus no additional therapy? And here the recommendation is that post-remission therapy should be offered over no additional therapy. And should older adults with newly diagnosed AML who are appropriate for anti-leukemic therapy but not candidates for conventional induction or post-remission therapy receive gemtuzumab, ozogamicin, LDAC, azacitidine, 5-day decitabine, 10-day decitabine as monotherapy or as a combination? And the recommendations here are that azacitidine monotherapy is preferred over LDAC, that 5-day decitabine is preferred over 10-day decitabine, that HMA-VEN is suggested over HMA alone, and that LDAC-VEN is suggested over LDAC alone. In older adults with newly diagnosed AML and targetable mutations that are listed here, who are not candidates for induction or post-remission therapy, should they receive HMA monotherapy, HMA-VEN, HMA-VEN plus targeted therapy, HMA plus targeted therapy, or targeted therapy alone? And here it really depends on the mutation, but if we're talking about IDH1 mutations, the recommendation is for azacitidine and ivosidenib over azacitidine alone, followed by either HMA plus ivosidenib or HMA-VEN. And for IDH2, this is where things are a little bit different. Azacitidine alone is recommended over azacitidine plus enasidenib. It's very important to keep this distinction in mind versus what we see with IDH1. And that HMA-VEN is recommended over HMA enasidenib. Next, should older adults with newly diagnosed AML who respond to HMA or LDAC-based induction and post-remission therapy continue with treatment indefinitely until progression, toxicity, or should therapy be given for a finite number of cycles? And right now, the recommendation is continue therapy indefinitely until progression or unacceptable toxicity. There's certainly a lot of interest in whether or not patients can discontinue HMA-VEN, but the data at this point I think is insufficient to recommend that. Should older adults with newly diagnosed AML who have a FLT3 mutation be offered a FLT3 inhibitor in combination with anti-leukemic therapy versus anti-leukemic therapy alone? And anti-leukemic therapy in combination with a FLT3 inhibitor over anti-leukemic therapy alone is the recommendation. Should older adults with newly diagnosed AML who respond to initial anti-leukemic therapy and are candidates for allo stem cell transplant for first remission and have non-favorable molecular or karyotype risk receive a stem cell transplant? And the answer here is to support allo transplant over no transplant. And finally, should older adults with AML who are no longer receiving anti-leukemic therapy receive red cell transfusions, platelet transfusions, or both versus no transfusions? And here the recommendation is red cell transfusions available over not having them available. This, of course, is a difficult point because many hospices will not accept patients who are continuing to receive red cell transfusions. So this is something that I think is clearly a quality of life issue, but even at the end of life. Okay, so moving on, now talking about some important therapy that was presented as a plenary talk at ASH. Paradigm. This is a trial of azacitidine venetoclax versus intensive chemotherapy in fit newly diagnosed AML. I think we've been waiting for a trial like this for quite some time. And of course, we've been using induction chemotherapy since it was described in 1973. But now with Aza-Ven and its terrific response rates, the question is it time to change? So the highlights here are that there were higher responses. The overall responses were 88% versus 62% in terms of a composite CR, which includes CR, CRHI, and CRI, and 81% versus 55% with azacitidine venetoclax versus intensive chemo. The CR rates were similar if we just look at CR. Now, improved event-free survival and transplant access. At 1 year, event-free survival was 53% with Aza-Ven versus 39% with conventional induction chemotherapy. And this was a significant difference. And more patients were able to proceed to stem cell transplant. Better tolerability and quality of life. Grade 3-4 toxicities were similar, but the 30-day and 60-day mortality were 0% versus 3.5% and 4.7%. There were fewer ICU admissions, fewer inpatient days, importantly, and significantly better quality of life, symptoms, and depression scores. So you see all of the data presented here in the table. I think this is really certainly an important paradigm shift. It's important to realize that patients with core binding factor or NPM1 mutant disease were not included here. So we're not talking broadly about all newly diagnosed fit AML patients. So it's important to look at this data carefully, but it does suggest that patients outside of that realm may have a better outcome with azacitidine and venetoclax. So a very, very important data from ASH. Ask for first. So this is asciminib in newly diagnosed CML, another important study from ASH. So here, asciminib is certainly a drug that has made a major impact in recent years. One of our newest TKIs, and the ongoing question in CML is which drug is best for which patient. And here, most patients on axitinib showed improved or stable quality of life through week 96, including global health status, physical functioning, and social functioning. And symptom burden improved more frequently with asciminib than with current TKIs, including fatigue, pain, and emotional and role functioning. And fewer treatment-related side effects were reported with asciminib, contributing to better tolerability and patient satisfaction. Now, of course, this is important because we've certainly seen that with second-generation TKIs versus imatinib, we often do see more side effects. But what we are now seeing is that a drug like asciminib that seems to have overall higher response rates is not being associated with higher toxicities. In fact, maybe improving overall quality of life metrics for patients. Okay, let's transition over to MDS and other bone marrow failure syndromes. In MDS, we have always had a difficult time in terms of understanding what should be the major endpoints of our studies, right? Are we talking about hematologic improvement? Are we talking about overall survival? Are we talking about CR? What does CR actually mean? And here, what this data showed from the meeting was a durable CR is a superior endpoint to hematologic response in MDS. So only durable CR of more than 6 months improved survival. The hematologic response offered no OS benefit, which is, I think, to maybe perhaps somewhat of a surprising finding. The landmark analysis confirmed these findings. A durable CR reduced risk of death by 34%, while short CR remained non-beneficial. And the durability was consistent across regimens. 87% of patients with CR with HMA alone, and 71% with HMA then, and 83% with HMA plus novel. Their trials were durable, and of course, this is important because we want this to be therapy agnostic and pertain to only what the underlying result is meaning for overall survival. And in TP53 mutated HR-MDS, durable CR remained prognostic. These are a difficult group of patients to treat. And again, we don't always know what it is that we are actually looking for as a response marker. So again, only durable complete remissions more than 6 months improve survival in high-risk MDS, making durable CR a practically and clinically meaningful surrogate endpoint that can better guide treatment evaluation and accelerate drug improvement. Now moving on to therapeutic aspects of MDS. This was long-term data from the phase 3 EMERGE trial of imetelstat and lower risk MDS. Of course, imetelstat is now FDA approved in MDS. And importantly, in this data set, median overall survival was 47.8 months with imetelstat versus 44.8 months with placebo. And there was an 18% reduced risk of death that favored imetelstat. Progression-free survival, the median PFS was 47.6 months versus 42.2 months favoring imetelstat. And AML progression was generally low in both arms, as we would expect. Responder overall survival was generally longer for more than 24 weeks and more than 1 year in red cell transfusion independent responders and hemoglobin rise responders as well versus the non-responders. So responder OS, overall survival generally longer for greater than 24-week and 1 year red cell transfusion independence responders and hemoglobin rise responders versus non-responders. The strongest OS signal was actually in SF3B1 mutated patients. In terms of subgroups, OS favored imetelstat in most predefined subgroups that are listed here, including RS positive and negative groups and those with a higher EPO level. And no new safety signals were observed. So the Pulse PNH study, this is a study of iptacopan monotherapy in PNH patients. And the highlights here are that hemoglobin increased significantly with the overall adjusted mean from baseline was 2 grams per deciliter. And this met the p-value for both non-inferiority and superiority in patients with baseline hemoglobins of 10 to less than 12. The mean increase was 2.4 grams per deciliter. No transfusions were required during the 24-week period. Improved hemolysis markers were observed, and the symptom and satisfaction gains were noted, as you see here. There was an increase in those measures as well. Overall, this was a treatment with not very high-grade adverse events, and these adverse events included headaches, diarrhea, nausea, and nasopharyngitis, but again at low levels. Okay, now let's transition to myelofibrosis. So again, we'll start with guidelines that were presented at ASH with regards to treatment. And again, I think it's important to review these guidelines, but again, to realize that these are suggestions based on, in many cases, limited evidence. So, extended NGS versus limiter driver-only testing wasn't discussed here, nor was the interferon in prefibrotic disease. Both of these things, I think, are again, debatable in terms of whether or not they should be pursued. In general, I would say that more extensive testing can be useful in terms of molecular drivers for prognostic purposes. And there's very limited data with prefibrotic MF with regards to interferon treatment, but there are trials going on currently. So I think we need to see what this data tells us. For JAK inhibitor use in higher risk asymptomatic patients, these suggestions are against starting JAK inhibitor in higher risk patients without symptoms or splenomegaly. And this is an important aspect, right? Because this does happen in practice that patients are seen who have higher risk disease, but who are generally functioning well. And there's always been a debate as to what to do with these patients. The current data would at least suggest, or the recommendations suggest not initiating therapy necessarily in those patients. What about JAK inhibitor use in lower risk symptomatic patients? The suggestion for JAK inhibitors for lower risk patients is again in patients with symptomatic disease. So again, the DIPS is really not being suggested as a way to decide who to treat. What about management of disease-related anemia? In JAK inhibitor-naive patients with MF, whose primary indication for treatment is disease-related anemia, the panel suggested either JAK inhibitor therapy with momelotinib or pacritinib, which have both shown some anemia benefit, or a non-JAK inhibitor anemia-directed therapy, for which there are numerous, such as ESAs. Management of drug-induced anemia, and this is particularly pertaining to JAK inhibitors. The recommendation is if anemia prevents optimal dosing of ruxolitinib or fedratinib, the suggestion is to switch to momelotinib or pacritinib. And if anemia develops on ruxolitinib or fedratinib, but symptoms and spleen control remain adequate, suggest adding a non-JAK inhibitor anemia-directed therapy rather than switching to momelotinib or pacritinib. This is important, right? Because there are patients who have a terrific response, spleen and symptom-wise, to, for example, ruxolitinib. And in those cases, the suggestion here means that adding an agent rather than switching may be the best opportunity. Timing of transplant consultation, early versus delayed. Early referral is favored for patients with high-risk molecular features, even if responding to JAK inhibitors. And that, to me, is sort of the key point, even if responding to JAK inhibitors. The final decision to go to transplant, of course, depends on a number of individual factors. The optimization before transplant was not discussed. Aspirin therapy in MF. Suggestion for low-dose aspirin for JAK2 mutant MF patients without contraindications was made, and for all other MF patients, shared decision-making with regards to individual factors was suggested. And iron chelation was not discussed. Finally, turning to data, clinical data for myelofibrosis, data was presented for follow-up of MANIFEST-2. This was a phase 3 trial of ruxolitinib and pelabresib versus ruxolitinib alone for patients with splenomegaly and symptoms from myelofibrosis that has previously not been treated. The primary data read out 2 years ago at ASH, and that showed that the trial met its primary endpoint and that spleen volume reduction was superior with ruxolitinib and pelabresib versus ruxolitinib alone. This is 96-week data follow-up. And the important things from this study were that the similar proportion of patients at week 96 remained on combination versus ruxolitinib alone, and that discontinuation was primarily due to physician decision and withdrawal of consent. But in terms of spleen volume responses, there's remained a really marked difference between the arms. At week 96, among evaluable patients, spleen response was seen in 91.5% of patients treated with combination versus 57.5% of patients treated with ruxolitinib. And importantly, this was durable. This was a durable response in that, as you see here on the graph, if you look at the median duration of spleen response, this was not reached with combination therapy, but it was 138 weeks with ruxolitinib. So in the hazard ratio of 0.692 was in favor of combination therapy. With regards to symptom response, the absolute symptom response favored combination numerically at week 24, and this continues to be the case at week 96. So we continue to see a numerical symptom difference in favor of combination therapy. In regards to anemia, there are trends favoring combination therapy. Hemoglobin response was higher with combination therapy, and there were fewer patients requiring red cell transfusions. In terms of safety, the AEs were largely the same across arms. The differences were there was more anemia with ruxolitinib, there was more thrombocytopenia with combination therapy, and there was more dysgeusia with combination therapy, but that did tend to respond to dose reductions of pelabresib. And really, 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 I think importantly, progression events and overall survival, right? The benefit of having longer term data is that we can look at these factors, which of course are important. And in fact, there were fewer progression events observed in combination versus ruxolitinib alone. There were more deaths reported in the ruxolitinib only arm. And in terms of leukemic progression, this was largely the same, between the two arms. So these are, I think, really important indicators of ongoing efficacy that favors combination of ruxolitinib and pelabresib over ruxolitinib alone. Finally, we come to the preliminary data from the Odyssey trial, which is a combination of momelotinib and luspatercept in transfusion-dependent MF patients. So what the data showed here is that transfusion burden was stable or reduced in most evaluable patients, 64% in fact, at the early time point that was reported here. Hemoglobin response was achieved in 40% of patients. And the spleen response was achieved in about 43% of patients. Hemoglobin levels increased at week 3 and remained stable through week 12 across cohorts, and platelet counts generally remained stable through week 12. Preliminary safety showed that 63% of patients experienced more than one AE, and there was no fatal AEs and no discontinuations of momelotinib or luspatercept. And the most common AEs were anemia and thrombocytopenia. And the dosing here was feasible. Patients were able to be maintained on therapy through week 12 with no major dose-limiting toxicities. So with that, thank you again for joining us for this clinical highlight titled Hematologic Cancer Updates, spotlighting key advances in leukemia, myelodysplastic syndromes, and myelofibrosis. Be sure to click Continue on the activity landing page to claim your AMA, ANCC, or ACPE credit and access the downloadable slides. Thank you.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and select Continue to move through the post-test and evaluation questions.